They will be doing
blood pressure.
yeah, so they will be anti means against, hypertension means against the hypertension. So antihypertensives they will be lowering our blood pressure. So antihypertensives can be given in the hypertensive situations, right? Hypertension situations. So hypertension is simply very simple. So first of all we are going to talk about the antihypertensive. So in a normal adult, what is the normal blood pressure? 120 over 80, in which 120 is systolic and 80 is diastolic, right? So this is the normal, okay, on an average normal blood pressure in a normal adult, right? Whenever this blood pressure, okay, goes high, or whenever the blood pressure starts to elevate, we need to take what? Antihypertensives, okay? One more thing, if the thing is, usually in our daily life blood pressure fluctuates, okay? Sometimes we are having lowering of blood pressure, sometimes we are having elevation of blood pressure due to some kind of stress and all these things, right? Due to adrenaline rush and all these things, right? But at what point of time you should take the medication? Whenever your blood pressure is exceeding some value. For example, if we will be talking about the systolic one, if it is exceeding at least more than 140, then you should be taking in those cases antihypertensives. Otherwise, below than that, it can be compensated easily. Whenever you will be overcoming your stress, it may come down, okay? For example, you saw something very horrible, okay, or you some ghost kind of thing or something like that. In those cases, your blood pressure might elevate, right? So after that, after some point of time, it will be coming down or not? It will be coming down as you will be overcoming your fear and all, right? So if you talk about antihypertensives, okay, let's talk about the classification of antihypertensives for the lowering of the blood pressure, right? So classification is very, very simple to remember and very, very easy to remember. As we have discussed, most of the drugs, not most, but some of them. So the classification is very simple, alphabetically, A, B, C, D and E, okay? Very simple. So A for apple. A for apple is correct, but in pharmacology. So A for what drugs have you studied till now, starting from the A? Atropine, but like okay, adrenaline. On more broader purpose, for example, tell me some class, not drug. Great. Anticholinergics. Have we talked about alpha blockers? Mainly the alpha 1 blockers we'll be talking about. Alpha 1 blockers, A for alpha 1 blockers. We have already talked about the alpha 2 agonist. Have we talked about or not? We have already talked about that, right? So these were the adreno blockers, these were the adreno mimetics. A for ACE inhibitors, okay, A for ACE inhibitors, and A for angiotensin receptor blocker, ARBs, okay? So this is the A, this is our A, okay? So alpha 1 blockers, alpha 2 agonist, ACE inhibitors and angiotensin 2 receptor blockers, or ARBs, okay, in short. Fine. Now B for somebody said bada apple. B for beta blockers, okay, B for beta blockers. C for calcium channel blockers, CCBs, okay. About these things, beta blockers, we have already talked about them in detail, okay. About the calcium channel blockers, we will be talking about them in the cardiovascular drugs, okay. However, I will be talking about some things, few points about the calcium channel blockers also. Diuretics also, we will be talking about the diuretics in next class, because it will make more sense, right? E for endothelin 1 receptor blocker, endothelin 1 receptor blocker, okay, very easy. At least classification is easy as far as antihypertensives are concerned, right? And already we have talked about the alpha 1 blocker. That will be easy for us to understand. Alpha 2 agonist, again that will be easy for us to understand. ACE inhibitors and ARBs will be also be easy because we already know about the renin, angiotensin, aldosterone, ADH pathway, right? We have already talked about the beta blockers. Calcium channel blockers, I will be telling some things. However, we'll be talking about them in details in some separate class. Diuretics also, I will be talking about diuretics in detail in separate class. However, I will be giving some few points. Endothelin 1 receptor blocker, that will be in the last. Okay, so let's start with the alpha 1 blockers. Okay, shall I rub this? No? Okay. So if you talk about alpha 1 blockers, tell me the location of the alpha 1 receptors. Blood pressure? Blood vessels, yeah, blood vessels. So in the blood vessels we had the alpha 1 blockers, alpha 1 receptors, sorry. And if you will be stimulating the alpha 1 receptors, what effect you will be getting? Huh? Increase in blood pressure. And if you will be blocking them, decrease in blood pressure. We are talking about the alpha 1 blockers. So what effect we will be getting? What effect we will be getting? Decrease in blood pressure. What effect do we want if we are talking about antihypertensives? We want to decrease the blood pressure, right? So alpha 1 blockers. Now I told you whenever I was talking about the alpha 1 receptors, I told you we are having subtypes in the alpha 1 receptors. That subtypes was alpha 1A and alpha 1B. Alpha 1A and alpha 1B. So this is alpha 1 receptor. So we are having the types. That was the alpha 1A and alpha 1B. Okay. What are the location? Tell me the location. Yeah, A for prostate, B for blood vessel, right? Very easy. B for blood vessel. So alpha 1A was present in prostate and alpha 1B was present in blood vessels. Then I told you about something that some of the drugs we are having in the alpha 1 blockers category, that they can block alpha 1A as well as alpha 1B. Some drugs we were having which were targeting alpha 1A only. Okay, so can you remind me those drugs? Yeah, so you remember about prazosin, doxazosin, terazosin, tamsulosin, silodosin, alfuzosin. So alfuzosin you can also add over here. They are non-selective alpha 1 blocker. Okay, non-selective, which means they can block alpha 1A as well as alpha 1B. So in which patients you can give them? First of all, I told you the indication is older age patients. I told you or not? Yes. Older age patients. So in the older age patient, what is the problem usually? In the older age, we see that they are having the problem in the blood pressure. Okay, most of the older age patients, hypertension problem is already there. And if they're having prostate problem as well, with one drug only you can relieve the symptoms of prostate as well as blood pressure. Okay, so you can lower the blood pressure, as well as you can relieve the symptom of BPH, that was benign prostate hyperplasia, right? Or benign hyperplasia of prostate. So these were the drugs which were working on both the things. Then there were one drug which was working only and only on prostate. Okay, which were working on prostate. What were those drugs? Silodosin, tamsulosin, right? So these drugs we saw. Alfuzosin, you can consider them in the non-selective category in the alpha 1. Okay, so what were the drugs? Silodosin and tamsulosin, right? They were blocking what? Selectively they were blocking alpha 1A receptor, not B, alpha 1A. Okay, so that's why selectively we were giving them in BPH patients. Those patients who are having the problem of BPH but not with the blood pressure. Okay, so they do not have blood pressure issues, but what they are having? BPH problem. Okay, in the antihypertensives, Okay, in the antihypertensives, we usually use these drugs, because if you will be using those drugs, they will not be working on the blood vessels, because blood vessels are having which receptor? Alpha 1 B receptor. Okay, so these drugs can we use in the cases of hypertension? Yes, we can use. Okay, yes, we can use those drugs. So prazosin, doxorubicin, terazosin, alfenazine, these alpha 1 blockers can be used in the antihypertensive classification. Okay, that was about the alpha 1 blockers. What can be the side effect of using these drugs for these patients? I told you over there. Yes, you should give them only during night time. Why is it so? Why you should give them only in night time, not during the daytime? You can give them in daytime also, but the thing is there is some complication of giving them, because as this is the problem of older age patients. Okay, the thing is about, it will be decreasing. So the problem is with the hypotension. If you're giving them during daytime, they will be doing their daily activities also. Okay, and in order to do that, if the hypotension will be coming, okay, they took the drug, okay, and they went on to doing some kind of physical activities, doing some kind of daily activity. After that time, during that time, what will be happening? They might be having the hypotension problem, which means blood pressure may drop. If the blood pressure will be dropping, the person will be falling. Okay, because this is an older age patient and their bones, okay, and their bones are not that good, so they might have fractures. If the fractures will be there will be much more time for the healing of those bones. So you will be having other effects also, other side effects also. If you are giving them in bad time, okay, they will be sleeping on the particular time, so you can overcome the blood pressure problem as well as hypertension problem. Okay, so that's why they should be given during the bad time. Understood? So that was about the alpha 1 blocker. About every drug, a common side effect, nausea, vomiting, of course, but after that, hypotension, because if you will be increasing the dose for such patients, the significance of giving the antihypertensive is to lowering the blood pressure. So if the blood pressure will be much lowering, then hypotension problem can be. The hypotension means decreasing or lowering of BP, right? Blood pressure. So that was about the alpha 1 blocker. Understood, everybody? Already we have talked about that. Okay, alpha 1 blocker, alpha 2 agonist. Alpha 2 agonist, epinephrine, norepinephrine, adenine, noradrenaline, they were non-selective. What? Agonist and agonist? Agonist, adrenergic agonist, right? Alpha 2 agonist, first of all, alpha methyl dopa and clonidine. Clonidine, alpha methyl dopa, these were the two drugs. These are the two drugs we were using, alpha methyl dopa and clonidine. So these were the drugs which we were using for what? For what? Hyper. Look how they will be overcoming hypertension. Tell me the location of the receptors, alpha 2 receptors. Presynaptically they were present. Okay, presynaptically they were present. So for example, if this is the neuron, adrenergic neuron over here, presynaptic and postsynaptic neuron over here, synaptic gap is present over here. What were the location? This was the alpha 2 receptor. Here we were having the presynaptic vesicle. What is stored over here? Yeah, norepinephrine, noradrenaline over here. Okay, as the calcium channels will be opening, voltage gated calcium channel will be opening, calcium influx will be there, then there will be the merging of these things. Due to the exocytosis, noradrenaline will be coming out over here. Okay, if it will be binding to here, alpha 2 receptors, there will be the negative feedback inhibition. I told you over there, negative feedback inhibition. So if there will be negative feedback inhibition, will that norepinephrine or noradrenaline will be coming out over here? No. So if noradrenaline will not be coming out over, can it bind to its receptors? No. Can there be the sympathetic outflow? No. If the sympathetic outflow will not be there, what will be happening to the blood pressure? It will decrease. So that's why we can use alpha 2 agonist in cases of hypertension. Can we use or not? We can use. What were the drugs again? Alpha methyl dopa and clonidine. These were the drugs because they can stimulate, not block. Stimulate. You need to stimulate them to overcome blood pressure, to lower the blood pressure at least, right? So if you will be stimulating them, negative feedback mechanism, negative feedback inhibition will be activated, then noradrenaline will not be able to come into the synaptic gap, they will not be able to stimulate the receptor, they will not be able to stimulate the receptors. What will be happening? Sympathetic outflow will be decreased, right? Understood? So that's why we are using alpha 2 agonist in cases of, we can use alpha 2 agonist in cases of hypertension. So that's why we are including the alpha 2 agonist in the cases of antihypertensives, right? In the classification of antihypertensives. Understood? What can be the side effect? Hypotension can be there, okay, because they are centrally acting. You need to use them very wisely, centrally acting, okay. So in some patients, hypotension is very common as far as alpha 2 agonist is concerned, right? So you need to give them wisely. Coming over to the ACE inhibitors, we had already talked about the alpha 1 blockers, alpha 2 agonist. That was kind of revision for you, but let's talk about the ACE inhibitors. ACE means angiotensin converting enzyme. Angiotensin converting enzyme, okay. So every med student knows about the RAS system, right? Every medical student knows about the RAS system, and okay, so RAS system, so let's revise that, okay. So you will be telling, okay, I will be writing. So first of all, renin will be there, coming from kidneys. Yeah, very good. Kidneys, right? Macular densa cells and all these things, right? Renin will be coming out. So here is the renin. Okay. From the liver, and from the liver, angiotensinogen will be coming out. So here is the angiotensinogen, which is the, of course, inactivated form. Okay, angiotensinogen is also here. Now angiotensinogen has to convert into angiotensin 1, and it will be converting by the help of renin. It will be converting by the help of renin, and angiotensinogen will be now it will be converted into angiotensin 1. Angiotensin 1 has to convert into angiotensin 2. Okay, and that was the thing we want. Okay, but what was the enzyme over here? Angiotensin converting enzyme coming from, very good. Okay, till now everything is clear. One more thing, ACE is converting your angiotensin 2 into angiotensin 2. One more thing is happening at the same time. You know, bradykinin is also getting destructed whenever ACE is converting into whenever ACE is converting angiotensin 1 into angiotensin 2. Okay, now what will be happening? Angiotensin 1 is converting into angiotensin 2 by the help of ACE. Also you are having the destruction of bradykinin. Okay, bradykinin. Further, you know the story, angiotensin 2 will be binding to its receptor. So angiotensin 2 receptor, okay, present on the blood vessels. They will be binding over here. Okay, what will be the effect? Dilation? It will be constricted. So if the blood vessel will be constricted, what will be the effect on the blood pressure? Blood pressure will be increased, obviously, right? Further, angiotensin 2 can go to your adrenal gland. There is an adrenal cortex. In the adrenal cortex, you are having zona glomerulosa. Zona glomerulosa is responsible for releasing your mineralocorticoid, that is aldosterone. Aldosterone can go to the distal part of your nephron inside the kidneys. So what will be happening? Sodium retention will be happening. If the sodium retention will be happening, water will automatically be retented or retained, right? And after that, what will be happening? Blood volume will be increased. If the blood volume will be increased, blood pressure automatically will increase. So if anyhow we will be able to block that ACE enzyme, angiotensin converting enzyme, okay, we can block this process. Yes or no? We can block that. So can we use ACE inhibitors? We can use ACE inhibitors. So these are the ACE okay, ACE inhibitors. I'm using that. So ACE inhibitors, they will be blocking which enzyme? ACE enzyme. If the ACE enzyme will be blocked, bradykinin will also not destroyed, so they will be remaining over here. Okay, bradykinin will also be remaining over here. No conversion of angiotensin 1 into angiotensin 2. There is no angiotensin 2. Will it be able to bind to its receptors? No. Will it be able to increase the blood pressure? No. So automatically blood pressure may decrease if it is high, right? So it will try to normalize that thing. Further, aldosterone, if the angiotensin 2 is not there, it will not be able to stimulate the zona glomerulosa. Aldosterone will not be able to come out. Aldosterone will not be able to go to the distal part of the nephron, and they will not be doing the retention of sodium and water. Okay, again, blood volume will not be increased, so blood pressure will also not increase. Okay, that's how we can use ACE inhibitors for decreasing the blood pressure. Does that make sense? It does, right? So that was the ACE inhibitor. I told you one more thing. ACE inhibitor is blocking or inhibiting the ACE enzyme. At the same time, bradykinin is not getting destroyed. So that bradykinin will start to accumulate in some locations. Okay? Yeah. And usually it can, because ACE was coming from lungs. Okay? So sometimes patients who are taking the ACE inhibitors, however, let me tell you, ACE inhibitors we are using very commonly in cases of hypertension patients. Okay? One more thing I would like to tell you over here, ACE inhibitors we are using in cases of diabetes very, very frequently. Okay, because it gives you relief in the cases of diabetic nephropathy. Okay, in the case of diabetic nephropathy, it can be used very easily. If the patient comes, diabetes and hypertension, this is very common combination in the patients, usually in the older age patients. Okay, older age patients are having a lot of problems. Diabetes and hypertension, these both are the chronic problems. Okay, diabetes can be there from 10 years, hypertension can also be there from 10 years. Patient will not die if they are taking proper amount of medication and proper time, right? So diabetes and hypertension, these are the common problems, and usually they come combinedly, okay, collectively. So in those patients, ACE inhibitors are very, very helpful. ACE inhibitors are very, very helpful. So depending on the situation of the patient, you need to choose your drug to lower the blood pressure. Okay, depending on the situation of the patient. Okay, however, very less doctors are following that policy. Okay, so the thing is, but these kind of things determines how you are going to treat your patient, in what time you are giving the result to your patient. Okay, so if you are using, for example, if you are using calcium channel blockers in the diabetic patient, okay, it will not be that helpful. There will be a side effect, then you will be controlling the side effect as well. Okay, so you are increasing the amount of doses. That will be good for your patient or bad? That is obviously bad for your patient. Okay, so you need to find out what is the best treatment for your patient. Fine. So for the diabetic patient, for the diabetic patient, okay, ACE inhibitors are very, very popular, and in the diabetic patient, whoever is having the hypertension problems. Okay, so I was talking about the bradykinin. They were not getting destroyed. They can accumulate inside your lungs, okay, and inside your upper respiratory tract. With that, there's a problem of coughing. So dry cough or the non-productive cough, that is the problem of using the ACE inhibitors. Okay, that is the problem of using the ACE inhibitors. However, if the problem is not coming, that problem is quite common. If you're giving the ACE inhibitors to the patients, okay, and dry cough is coming in that patient, that can be overcome. You should stop the ACE inhibitors at that time, and then you can use angiotensin receptor blockers. Angiotensin receptor blockers, also called as ARBs, ARBs, ARBs in short. Okay, what will be the function of angiotensin receptor blockers? Very easy. So let's say these are the ARBs over here. Okay, they will be blocking what? Receptor, angiotensin receptor blocker. Okay, so if the angiotensin is also there, it will not be able to bind. It will not be able to bind to the angiotensin 2 receptor. If it will not be able to bind to the receptor, they will not be able to increase the blood pressure. Okay, are they doing anything with the bradykinin and all? Okay, so if the coughing problem is there, stop the ACE inhibitors and add the angiotensin receptor blockers. Okay, because coughing problem is very, very common in this case. One more problem is very, very common, that is the angioedema. What is that? Angioedema. So there can be the periorbital edema in those patients, and as well as there can be the swelling of this perioral region. Swelling of the perioral region. Okay. Fine. So that was about the ACE inhibitors and the angiotensin receptor blockers. But till now we didn't talk about drugs. So let's talk about the drugs. Alpha 1 blocker, we talked about that. Alpha 2 agonist, we talked about that. ACE inhibitors, they are ending with the prils. They are ending with prils. So you can remember them with the prils. Okay, they are ending up with the prils. Suffix is prils. So what are these prils? Shall I rub this one? So with the prils, right? For example, lisinopril, captopril, enalapril. Okay, so these kind of pril you can use for ACE inhibitors. Okay, ACE inhibitors. So they are ending up with the pril. Okay, talking about the ARBs, they are also called as sartans. Also called as sartans. SARTANS. Okay, for example, losartan, candesartan, valsartan. Okay, these can be the drugs for the angiotensin 2 receptor blockers. Okay, angiotensin 2 receptor blockers. These are the drugs for the ACE inhibitors. Fine. So ACE inhibitors ending up with the pril, suffix is pril, lisinopril, captopril, enalapril, angiotensin receptor blockers, losartan, candesartan, valsartan. These are the drugs, okay, which we can use as antihypertensives as far as ACE inhibitors and ARBs are concerned. Right? Any problem till now? Okay. What can be the side effects for using the ACE inhibitors and the ARBs? About the ACE inhibitors, I told you dry cough can be there. I told you about the angioedema. Okay, then hypotension, obviously in both the cases. In every kind of antihypertensives, hypertensive problem can be there. Don't say nausea, vomiting. Okay, then what else can be there? In cases of renal stenosis, okay, renal stenosis or some kind of arterial stenosis, you should avoid such drugs. Okay. One more thing, you should, if the patient is having diabetes mellitus, you should be giving the ACE inhibitors or angiotensin receptor blockers to them. However, ACE inhibitors, angiotensin receptor blockers, they should not be used combinedly, because during one study it has been found that there is no particular benefit for using ACE inhibitors and the ARBs combinedly. So if the dry cough is coming, the dry cough problem is coming in the patients who are taking the ACE inhibitors, you should stop first of all ACE inhibitors, and then you should add angiotensin receptor blockers or ARBs. Okay, and these are the drugs which we are using in the ACE inhibitors and ARBs respectively. Fine. Now let's talk about